everyone. I'd like to start with thanking the organizers for selecting this talk for the presentation. And I'm very excited to present our findings on behalf of my co-authors that you can see on the slide. Am I doing something wrong? The other one. So to start, I'd like to acknowledge that the research that you'll hear about today was done on the traditional, ancestral, and ceded territories of the Coast Salish nations, including Musqueam, Squamish, and Tsleil-Waututh people, and that's in Canada. So my talk today is about cardiovascular risk in women. And we talked about it yesterday a little bit, and I think it kind of works nicely in terms of the program. And a really important point from yesterday that I liked was that there are risk factors for heart health in women living with HIV that we measure, and there are some that we don't measure and that we know they are important. But to broadly group them, we can think of them as traditional risk factors, so things we usually think about when we think about heart health: hypertension, dyslipidemia, diabetes, obesity, and smoking. Then there are factors specific for HIV, so things like higher prevalence of latent infections, such as hepatitis B, hepatitis C, cytomegalovirus, and others, inflammation, immune activation, and effects of treatment. Then we have some factors specific to female sex, and these are mostly hormone regulated, and they include pregnancy, hormonal fluctuations due to menopause and other conditions, and disproportionate stress. And lastly, we know from previous research in women living with HIV that they experience higher burden of traditional risk factors and higher burden of sociostructural adversities compared to women not living with HIV and men living with HIV. And all of this affects their heart health. Of course, on the population level, primary prevention becomes very important. And primary prevention refers to all efforts aimed at either populations or individuals to prevent or delay the onset of atherosclerotic cardiovascular disease. Of course, there are many strategies in primary prevention. The main ones are behavioral counseling, so counseling about smoking cessation, diabetes prevention, hypertension, then addressing social determinants of health, but very importantly, pharmacotherapy for some people at increased risk is a part of primary prevention. And this is when cardiovascular risk calculators come into play. Once again, they were discussed yesterday at some capacity, and the idea of these calculators, although we know they have some limitations, and I'm going to talk about them as well, is that they help us stratify individuals without cardiovascular disease, so people who have not had any heart attack or stroke, based on their risk of experiencing cardiovascular event in the next 10 years. And so, as we heard yesterday as well, that in some of the clinical guidelines, these risk calculators are incorporated. Some clinicians use them in patient counseling, and they're widely used in research. The output of these risk calculators is usually a 10-year risk of atherosclerotic cardiovascular disease, which is expressed in percentages, and this is what we'll be talking about today. So in my project, we looked into two calculators. So the first one is ASCVD or PCE, but this slide has a lot of abbreviations, so I'm going to go through them first. So ASCVD stands for two things at a time. So atherosclerotic cardiovascular disease as a condition, but also this is a name of a calculator that measures the risk of ASCVD, which is why I'm going to be referring to the first calculator by its second name, which is PCE, pooled cohort equations, and you might have heard about that yesterday. The second calculator is PREVENT, which stands for Predicting Risk of Cardiovascular Disease Events. And you can see in the tables that contrasts both, that they were developed 10 years apart, and PREVENT is the more recent one. So ASCVD, or PCE, I should say, was developed to address the limitations of the Framingham risk score that were used before that, and PREVENT was developed to address the limitations of ASCVD. Now, what are these limitations? So the landscape epidemiologically of cardiovascular disease changed. The treatment improved. There is more treatment for high lipids, more treatment for hypertension. PREVENT actually widens the age range for which it works. So ASCVD, I really should be saying PCE. PCE starts from 40 years old and PREVENT starts at 30 years old. And importantly, PREVENT excludes race or ethnicity from its calculation in response to many, many studies that were showing that PCE either underestimates or overestimates risk in different populations. Now, both of these calculators use shared variables in estimating the risk, And these are just common traditional risk factors for cardiovascular disease. So age, sex, total cholesterol, high density lipoprotein, history of diabetes, systolic blood pressure, smoking status, and treatment for hypertension. When it comes to differences, PCE considers race, ethnicity, and PREVENT doesn't. And additionally, it incorporates body mass index and estimated glomerular filtration rate in the recognition of cardiovascular metabolic kidney syndrome and the relationship between metabolic health, heart health, and kidney health. And PREVENT accounts for lipid-lowering medication use. Now, I would like to also emphasize that in this particular project, we just use the base models, but there are certain things you can adjust for in kind of more elaborate models for both calculators. In PREVENT, in particular, you can adjust for HbA1c if you want. You can adjust for urine albumin to creatinine ratio, and you can adjust only in the United States for social deprivation index, which is a postal code-based estimate of a social deprivation in the area where the person lives. But our study is in Canada, so we did not do any of that. So with all that in mind, we know that all these calculators, they are developed in the general population, and when it comes to people living with HIV, they show inconsistent risk stratification, with the biggest problem being that they underpredict risk, particularly in women and in racialized groups. When we saw the new calculator published, we were curious how it compares to the PCE, which was the main one being used and talked about in big studies. And so with this particular project, we sought to investigate the concordance between PCE and PREVENT in a cohort of women living with HIV and without HIV. So the cohort in question is a Canadian cohort called BCC3, which stands for British Columbia Carmody US Collaboration Study. It is an ongoing cohort study that started recruiting in 2020, and it recruits women living with HIV residing in British Columbia and sociodemographically similar controls, and that is an important feature of the study. The project is community-based, which means a lot of things. Among them, community research associates are an integral part of our team from the conception and all the way through administering surveys and knowledge mobilization. We have community advisory board meetings and knowledge translation and exchange events. The overall objective of the project is to better understand aging in women by examining the relationship between various factors that can affect aging. So that includes inflammation, hormones, sexual health, immune aging, stigma, discrimination, chronic pain, and many, many others. Of course, I cannot list them all. For this particular project, we included all women between the ages of 40 and 79 years old who did not have any history of cardiovascular disease and had complete data. That left us with a sample of 141 women living with HIV and 147 women without HIV. So the table you can see here is a demographic table, and let's go through it together. But one thing I'd like to emphasize right off the bat is that I did mention that the study very purposefully recruits women without HIV who are sociodemographically similar because we want to understand how social adversities affect health. And this is reflected in very few significant p-values on the table, which is a good thing. But to go through them one by one, the age was similar between the groups, kind of early to mid-50s. Similar proportion of women in both groups experienced homelessness, over 40%. There was a difference in ethnicity driven by the fact that we were not able to recruit enough women without HIV who identified as African Caribbean Black. Similar proportions of women in both groups reported current tobacco smoking, around a third. Around 20% in both groups reported current substance use, and there was similar proportion of women who reported treatment for hypertension and history of diabetes. And now the two important differences was that women living with HIV were more likely to be seropositive for hepatitis C, and they were more likely to use lipid-lowering medication. But once again, as I mentioned, it is important to look at these prevalences in the global Canadian context. And even though we don't see differences between the groups, if we look at the Canadian statistics for some of these determinants, social determinants of health, we can see how women in both groups in our study are more likely to experience social adversities. So when it comes to homelessness, for example, the Canadian estimates for women is 2% for unsheltered and 14% for hidden homelessness, while we see over 40% in both groups. And the same is true for smoking, so we have 3 times the national rates, and for substance use, we have 7 or 8 times national rates for current illicit substance use, which does not include cannabis. So now on to the results. So 2 risk calculators are introduced. We compared how they classify women. So you can see on the right the categorical classification into the risk group categories. So we have low risk, less than 5%, borderline risk, 5 to 7.4, intermediate, and high. So we saw how these calculators agree in putting women in this category. So overall, for 78% of women, both calculators agreed, but that results into moderate agreement when you use inter-rater agreement metrics such as Cohen's kappa. Importantly, among disagreements, 94%, so there was like just unidirectional, direction was one way, 94% of disagreements were from PCE assigning a higher risk category. Now, to examine agreement between 2 raters, which in our case is 2 calculators, Cohen's kappa is used, and you can see this little table on the right as a reminder of interpretation. So the agreement coefficient ranges from 0 to 1, the higher the better, basically. And you can calculate kind of Cohen's kappa classic, or you can calculate weighted Cohen's kappa. And these are the 2 columns in the table that you see. And the weighted Cohen's kappa just accounts for the order of the categories. Because obviously it's a bigger of a problem if you move somebody from low to high versus from low to borderline, as these are neighboring categories. So if we look into the actual Cohen kappa coefficients, so overall for all the women, it's 0.46, which is moderate agreement, and weighted kappa is 0.59, which is still moderate agreement. And then we're also curious to see if this agreement changes if we stratify women based on various social determinants of health, such as substance use, homelessness, history, HIV status, and history of hepatitis C. And if you just look at the numbers in the table, all of them, with very few exceptions, fall into the category of moderate agreement, regardless of all of these social determinants of health and HIV status, which we thought was interesting. So to summarize, PREVENT and PCE show only moderate agreement, both overall in our sample and within social demographically defined subgroups in our study. This discrepancy can affect primary cardiovascular disease prevention in women living with HIV in future. And of course, the optimal model for the use in this population needs to be investigated further. Now, when we saw these findings, we were wondering how they align with research in other studies. And so I would like to reference 2 studies that did some similar analyses. One was a Croy poster from UCSF, and they did a similar analysis in a cohort of mostly men. There were some women there too, but predominantly men. And they found that risk was lower, so the point estimate risk was lower in 95% of individuals based on PREVENT, and 56% fewer people with HIV would be recommended statins based on the 5% threshold. And that ties nicely with yesterday's debate, which I thought was neat. And another study on the general population in the US concluded that PREVENT would reclassify approximately half of the adults to lower categories, so similarly, kind of 50% estimate. But when they extrapolated that on the whole population of the United States, they concluded that number of adults receiving treatment would decrease by an estimated 14 million. So something to think about. But that is all I had to share with you today. And to conclude, I'd like to thank many people, but first of all, the women who participated in our study, our team, co-investigators, and the workshop committee for supporting my attendance of the conference. And if you want to learn about our study, you can use the QR code. Thank you.